dear postgraduates, today's class will be on the thyroid disorders, very common disorder in our society. I think nearly more than the 50 million people in India suffer from the thyroid disorders. Hypothyroidism, you know, both the overt and the subclinical. So depending on if you are TSH and the T4 levels, is the commonest thyroid disorder, affecting approximately 1 out of the 10 persons. So very high incidence of the thyroid disorders in the society. And of course, not only with the hypothyroidism, we also have some cases of the hyperthyroidism, that is thyrotoxicosis, thyroid nodules, and sometimes thyroid carcinoma. So these four are the very important disorders: hypothyroidism, nodules, and carcinoma of the thyroid. If you see the anatomy of the thyroid, very small gland, weighs about 15 to 20 grams only, but the deficiency or hypersecretion will cause almost all the disorders in almost all the parts of the body, whether it is cardiovascular, neurological, respiratory, etc. and etc. So the effects of either hypo or hyper will be there in all the systems of the body, but the thyroid gland weighs just 15 to 20 grams. It has two lobes, right lobe and the left lobe, connected with the isthmus, a dumbbell-shaped organ, over the trachea and also the below the thyroid cartilage. It also has the four parathyroid glands. They lie behind the thyroid gland. They also play a major role in your calcium metabolism. The recurrent laryngeal nerves lie in close proximity. That is the reason in thyroidectomy, the surgeons will be very careful not to dissect the recurrent laryngeal nerves. Otherwise, the people will have the hoarseness of the voice, etc. So voice change will be there. So this is some of the important points as far as the anatomical points of the thyroid is concerned. Now move on to the physiology. The basic unit of the thyroid gland is the follicle. It's almost like a necklace shape. So each follicle has a necklace of the follicular cells. So these follicular cells enclose the colloid. So the internal one is the colloid, surrounded by the different follicles. This colloid is composed of the thyroglobulin, from which the thyroid hormones are synthesized. So obviously we need T3 and the T4. These two are the thyroid hormones. So they are coming from the colloid. So the colloid contains the thyroglobulin, and colloid is surrounded by the follicular cells. The same picture here. These are the follicular cells. The inside is the colloid. So you are having the thyroglobulin. So this is the cell of your thyroid. So if you see the biosynthesis and the secretion, so this is an important slide. You please play a little more concentration here. So the one is you will have the colloid. Already show you the necklace of the follicular cells. So the center one is the colloid. It contains the thyroglobulin. So in the capillaries, you will have the iodine. So the iodine will enter into the cell. So there will be the trapping of the iodine will be there. That may be the 2A and the 2B, and the active form of the iodine will be there. So before the iodine, you will have the thyroglobulin that is synthesized and discharged into the follicular lumen. And you will have this iodine enters the follicular lumen, they attaches together. So they form the either MIT or the DIT. So monoiodothyrosin or diiodothyrosin. So with this thyrosin molecule and with the iodine combination, you will have either the mono or the di. So these two dyes will have the T4 and the 2 plus 1. That means one MIT and one DIT, you will have the T3 levels, or the two DITs, you will have the T4 levels. Era, Babu and Raman. Okay, right. See that two DIT and the one MIT, so that these two will form, you will have the T3, and the two DIT is combination of the two DIT, will have the T4. So that is how you will have this thing. So to form a good molecules or the good hormone, either the T3 or the T4, you need thyrosin, you need iodine. So these iodine and the thyrosin will form the MIT or the DIT, and the two DITs will get the T4, and one DIT plus one MIT, you will get the T3 levels. So D means di, M means mono. So this thyroglobulin colloid is combined with the lysosomes and finally to the peripheral tissues through either the T3 levels or the T4 levels. So the same thing here, the tyrosine, monoiodotyrosine, diiodotyrosine. So the triiodotyrosine is the T3 and the tetraiodotyrosine is the T4. So you have this orchestra boss of this hormonal orchestra is the hypothalamus. So in the hypothalamus it secretes the TRH that stimulates your anterior pituitary gland to secrete more and more TSH, and this TSH will stimulate your your thyroid to release the T3 and the T4 levels. You also have the negative feedback. Suppose if you have the more T3 and the more T4, so that gives the signals to both to the hypothalamus and also to the pituitary not to secrete the TSH or the TRH. So that is how we maintain the normal T3 and the T4 level. Suppose for some reasons we are secreting more and T4, more T3, so it gives the signals to the hypothalamus not to secrete the TRH, so that no TRH will be there, so then it won't stimulate the pituitary to secrete the TSH, and then the T3 and T4 levels will be under normal circumstances. So when you have this mismatch between these T4 levels, the T3 levels and the TSH and the TRH, so obviously the changes in the circulation, you can see whether it is a lower T3 or the lower T4 or higher T3 or the higher T4 levels. So we respect the hypothalamus, we respect the pituitary, and also we double respect the thyroid gland for its proper secretions of your T3 and the T4 levels. As I told you that we have the two major thyroid hormones, the T4 and the T3. So the T4 is the thyroxine, that is a major hormone in the circulation, and the T3 mainly derived from the peripheral tissues from the T4, six-fold more potent than the T4. So the T3 is more potent than the T4, and the T3 is derived from the T4, but the T4 is only from the thyroid gland. So what are all the T4 you see in the circulation is secreted from the thyroid gland, whereas the T3, from the T4 it is converted to the T3, and this T3 is much more superior or active than the T4 levels. So transportation is via the plasma proteins in the three ways. So the proteins are also very important. They are the binding proteins. So thyroid binding globulin, thyroid binding albumin, thyroid binding prealbumin is also available, is also needed for its proper circulation in the peripheral tissues, so that all these thyroid hormones will reach the different places or different sites, distal tissues, through this binding with the globulin or the albumin or the prealbumin. So how do the thyroid hormones act? So the thyroid hormones receptors are present mostly on the nucleus. So you have the receptors. So these hormones will bind to the receptors, and then they activate the genes involved in the energy and the chemical process. Each and every tissue in the body, they need the thyroid hormones for its fuel efficiency. So as I told you that they are bound to the proteins, how much bound, how much free. So if you see the T3, it is about 99.7% bound and the free is only 0.3. Whereas the T4 is almost 99.98% bound to your globulin or albumin or the prealbumin. The preform is only 0.02. So this is very important as a physician point of view, because if you check the TSH levels and if you check the pre-T4 and the pre-T4, T3, you will know the differences between these values. Even a small change in the T4 will make a very big change in the TSH. So if you see that 0.02 is the free T4, suppose 0.04 is your free T4, that means a lot of difference in the TSH levels will be seen. So not only the TSH, we also give a lot of respect to the free hormones of either the T4 or the T3. Mostly T4, we give a lot of respect after the TSH. As I told you earlier that the binding proteins bound to the thyroid hormones, 70% is the globulin, 20% is the prealbumin, and the 10% is albumin. So 100% of the thyroid, it attaches to the proteins. Either it is a globulin, 70%, albumin, 10%, or prealbumin, 20%. See the total thyroid hormones. Here the total T4, not the free T4. See the total T4 and the total T4, the two things. Here, the more thyroid binding globulin, the normal free hormone. Normal free hormone is the normal, same in both the graphs. You can see the normal free hormone is the normal, same. But what about the binding globulin? In the second picture is less, in the first picture is the more. So if you see, this is the total T4 is totally different from the free T4s. So what are the actions of your thyroid hormones? So mostly the three types. One is the growth. You all know that growth is very important in the children, otherwise they become the cretin. The development is also very important. And of course, in the adults, the metabolic effects are also equally important. So as a physicians, we are much more important is the metabolic, whereas the growth and the development will be dealt by our pediatric friends. So according to the metabolism, the thyroid hormones increase the basal metabolic rate and the heat production. That is the reason the people with the higher T4 levels, that means hyperthyroidism or thyrotoxicosis, so they will be having higher metabolic rate, higher hunger, higher thirst, increased appetite, etc. They increase the glucose production as well as the utilization. So this is also very important. That is the reason hypothyroidism is very common with the type 2 diabetes, because it is very much related with your glucose production and also glucose utilization. They oxidize the fatty acids and they lower the levels of the total cholesterol and the triglycerides. The same thing happens in the hypothyroidism. So in hypothyroidism, you will have the dyslipidemia, you will have the hypertriglyceridemia, increased LDL levels, increased cholesterol levels, and reduced HDL levels just because of the thyroid hormonal deficiency. So the deficiency, what will happen? So they will increase these levels of the cholesterols and the triglycerides. Other homeostatic body processes, including the heart rate. So heart rate will be bradycardia in hypo and tachycardia in hyperthyroidism. Gastrointestinal emptying. So there will be increased stools, increased number of the stools in hyperthyroidism, whereas the constipation is the rule in hypothyroidism. And also activated by, these are also activated by the thyroid hormone. So both the gastrointestinal, respiratory, cardiology, neurological, everything, every system will be disturbed by the dysregulation of your thyroid hormones. A few points on the growth. So thyroid hormones are essential for the growth and the pubertal maturation. So if you don't diagnose the hypothyroidism in the children or in the young adults, so definitely the growth will be disturbed. Development, yes, fetal brain development is influenced by the thyroid hormones. So their mentality or their mental maturity also will be reduced. So they will be idiotic in the presence of hypothyroidism if you don't diagnose in the children. So these two are the very important effects. The Wolff-Chaikov's effect. So what it means? Higher dose of the iodine causes the cessation of the hormone formation. I told you that iodine is very much essential for your T3 and the T4 levels. So diiodothyroxine and monoiodothyroxine, etc. So iodine is very important here. So higher dose of the iodine causes cessation of the hormone formation. So this effect is countered by the iodine leak from the normal thyroid tissue. So somehow iodine enters into the thyroid tissue. So then enter into the thyroid tissue, they will cause more and more hormone formation. So as a protective mechanism, as a counter balance, so what will happen? The iodine leak will be there from the normal thyroid tissues. The patients with autoimmune thyroiditis may fail to adapt and they become the hypothyroidism. That is Wolff-Chaikov's effect. So the reverse one is the Jod-Basedow effect. Here the opposite of this Wolff-Chaikov's effect, the excess of iodine induces the hyperthyroidism due to loss of the autoregulation. So what happened in the Wolff-Chaikov's effect? Iodine is there, more iodine is there. So definitely you get the hyperthyroidism, but there will be the leak of this iodine from the thyroid tissue and there will be the autoregulation. That's how you maintain the euglycemia. Otherwise they get the hypothyroidism. But here there is no loss of the autoregulation, total loss of the autoregulation. So what happens? So whatever the iodine enters the cell, there will be hyperthyroidism, hypersecretion. So they cause hyperthyroidism. So Jod-Waspos effect is the hyperthyroidism effect due to the loss of the autoregulation. Observed in the hypothyroid diseases like Graves' disease, toxic Gauge titer, toxic single adenoma. This effect may lead to the symptomatic thyrotoxicosis in patients receiving large doses of iodine in the form of diet, contrast administration, medications, etc. So as a physician, we are very much interested in the amiodarone. We use a lot of amiodarone in the tachyarrhythmias and also contrast. Your CT contrast, your MR contrast, etc. They use iodine. Even in the cath labs also they use iodine during the coronary angiograms, etc. So this is very important. Now we'll move on to the clinical assessment of the thyroid disorders. So after knowing something about the anatomy and the physiology and how they secrete, etc., So we'll move on to the bedside. So the patient history. History taking in the thyroid disorders. So I am always stressing that history is very, very important for a physician point of view. With history alone, you should come to a reasonable diagnosis in about 70 to 80% of the cases. So your examination, your investigations, etc., will help you. But the most important in coming to a reasonable diagnosis is always the history. So clues in suspecting either hypo or hyper. So there's a different historical issues. Goiter, enlarged goiter. So that could be both hypothyroidism and hyperthyroidism. Okay. So in hypothyroidism, some people will have the goiter because of the iodine deficiency. It's very common in Arku area, Paderu area, and also in the Himalaya areas. So where the iodine deficiency in the water, iodine deficiency in the soil, etc. So the enlarged thyroid is the goiter. And the hypothyroidism people, they will have the dry skin, cold intolerance, they gain weight, so obese, despite decreased appetite. Even though the appetite is low, so they increase the body weight because of the hypothyroidism. This is the important clue to you. So what happens when they decrease the weight, the appetite? So obviously they lose weight, but here they gain weight. So in spite of the decreased appetite, so suspect hypothyroidism. Depression is very common in hypothyroidism people. Some people, they behave like psychiatric people when there is a moribund hypothyroidism. So definitely they behave like very, very depressive, lazy, drowsy, sleepy, etc. Forgetfulness, fatigue, easy fatigability, myalgias, muscle aches, menorrhagia, infertility, constipation, dry, coarse hair and hair loss, hoarseness of the voice. So this is the very common when the TSH is beyond 100. So sometimes we see with the TSH more than 100. So what is the normal TSH? Normal TSH 0.5 to 4.5, etc. Okay, once it is more than the 5, it is abnormal. Once it is more than the 10, very, very abnormal. 5 to 10 is subclinical, more than 10 is clinical. So when the TSH is more than the 50 or 70 or 100, some people, so they will have all these features. They are the drowsy, so change in the voice will be there. They are the obese, loss of appetite. So this is the thyrotoxicosis. So these people also will have the goiter. So by just seeing the goiter, we don't know whether the fellow is a hyperthyroidism or hypothyroidism. Obese and goiter, so mostly the hypothyroidism. And lean and the goiter, mostly the hyperthyroidism. Hyperthyroidism. Okay. So the goiter is there. The fellow is very drowsy. So definitely it is a hypothyroidism. So warm and the moist skin, heat intolerance, weight loss despite increased appetite. What is the other condition where you will have the weight loss despite very increased appetite? More and more appetite. Good. Type 1 diabetes. Yes, very good. In type 1 diabetes also you will have polyuria, polyphagia, polydipsia and unintentional weight loss. Nervousness is a feature in thyrotoxicosis. They will have the tremors, difficulty in the sleeping, irritability, myalgia, hypomenorrhagia, infertility in both hypo and hyper, frequent bowel movements, whereas the constipation in hypothyroidism, bulging eyes, ophthalmopathy. So you will have the different signs in thyrotoxicosis or Graves' disease and ophthalmopathy. That's very common. And also the profuse sweating. So almost in very high hypothyroidism or high thyrotoxicosis, so almost these two cases are the spotters for any experienced physicians. So we'll see just while talking, while entering into the chamber, while sitting on the chair, and while answering the questions. So definitely you can come to a reasonable diagnosis of either hypo and hyperthyroidism. So history taking is an art. History of the neck swelling with the duration. If the person is having the goiter, ask for history of the presence of the pressure effects like the voice change, throat pain or the discomfort, persistent cough, breathing difficulty or dysphagia. So these are all the compressive features. So it could be a malignancy of the thyroid or any toxic nodular goiters or solitary goiter. solitary nodules, etc. So the compressive features also you should ask in any people who are having the goiters. History of consumption of the non-iodized salt. In children and the adolescents, history of the growth impairment, delayed or early puberty, and decline in the academical performance, delayed dentition may suggest the hypothyroidism. Drug history is also important, like amiodarone, lithium, steroids can alter the steroid function. Sorry, can alter the thyroid function. History of neck radiation, neck surgery. So they cause post-surgical hypothyroidism. Post-thyroidectomy. So you should supplement the thyroid, levothyroxine for lifelong. Post-thyroidectomy and post-irradiation. History of the other autoimmune diseases like lupus, rheumatoid may coexist with autoimmune hypothyroidism or hyperthyroidism. So very common autoimmune Hashimoto's thyroiditis. So in all the Hashimoto's thyroiditis, you should suspect the other autoimmune diseases, especially in the females. The common autoimmune diseases to suspect are rheumatoid arthritis or the lupus. Some people have the vitiligo, etc. So the family history of the autoimmune or the autoimmune endocrine disorders is also important. So in taking the history, so these are all very important. All these points you should ask. So whether the patient is hypo or a hyper, and then neck examination is very important if the person is having the goiter, and then ask about the salt, iodized salt or not. Now 100% salt available outside is iodized in India. So big thanks to Dr. Kochupallai. So he was the professor of endocrinology in AIIMS way back in 50s, early 50s. So when the AIIMS was introduced or started, he was the professor of the general medicine in charge of endocrinology. So he used to see a lot of the people coming to AIIMS Delhi from Srinagar and Himalaya areas with a lot of the goiters. So almost the goiter touches his knees. So some people even it touches the foot also. So that much of the goiter. So they live. So finally he thought that what could be the reason for this high incidence of the goiters, especially in the Himalaya region. So some fellow coming from the Punjab or some fellow coming from the Andhra Pradesh or Tamil Nadu, they are not having that amount of the goiters. So he suspected something wrong with those areas. Then he went there in the Himalaya areas. So he suspected that iodine deficiency in that particular areas is there. So then he suggested the central government to add iodine with salt, because salt is very, very important for anyone, whether they are Hindus or the Christians or the Muslims or the Sikhs, etc. So they consume salt irrespective of their religion. So sometimes onions. So Jain people, they don't take it. So if you take some non-vegetarian, maybe some pure vegetarians, they may not take it. So some milk, maybe pure vegans, they may not take it, milk and milk products. But salt, everyone will take it. Then he suggested the central government to add iodine to the salt. And for that, he was awarded Padma Shri and Padma Bhushan also. So very big change, a game changer as far as the iodine disorders is concerned is Professor Kochupallai. So he was the professor of medicine and endocrinology at AIIMS. So that is the salt. So children, and these are all the history points you are supposed to ask him. So even there is an adult sitting before you, you should ask something about the history in the childhood. So about any mental, academic performances. And then the drug history is very important. And history of the thyroid surgeries, because there will be a scar will be there. So obviously you can ask what is the reason for that scar. Then they say that some surgery was done maybe 10 years ago or 15 years ago, etc. So the total thyroidectomy was done at that time. So they were not introduced the thyroid hormones. Now the patient presents with hypothyroidism or profound hypothyroidism. So autoimmune disease is very common in the females because thyroid 90% is the females. So examination is very important after the history taking. So hypothyroidism, generalized edema, facial puffiness, facial edema. So it is not pitting edema, non-pitting edema. So the pitting edema is very common in heart failures, nephrotics, etc. Non-pitting edema, ER, in hypothyroidism. And the goiter is a very common. And then see whether the right lobe of the thyroid is enlarged. or the left lobe of the thyroid enlarged, or total gland is enlarged, or the isthmus is enlarged. This is very important. And the skin dry and scaly skin. Slowness of the movements. So very common in hypothyroidism. Almost like your Parkinson's disease. The spasticity. Bradycardia. So you have to record the pulse rate, heart rate. So here the bradycardia, maybe the 40 or 45, the 50. Brittle nails. So nails also is very, very important for the physician. So you will see the nails. Some diseases you can decide with the nails only. Some fungal infections, some psoriasis, some pittings, anemia, koilonychia, clubbing. Okay. So these are very common. Generalized pallor. Delayed relaxation of the deep tendon reflexes, especially ankle jerk, and hoarseness of the voice. In thyroid toxicosis, you will have the thyroid associated ophthalmopathy, enlarged goiter, warm and the moist palms, anxiety, restlessness, hyperactivity, tachycardia, atrial fibrillation, panicolysis, clubbing, acropathy, wide pulse pressure, proximal myopathy, pretibial myxedema. So here the separation of the distal part of the nail from the nail bed is called onycholysis. This is very common in hyperthyroidism cases. If you see the nails, so the separation of the distal part of the nail from the nail bed. So now come to the lab. So after the history, after the examination, so take the help of the laboratory people. So as a physician, we should respect all the laboratory people, whether it is a biochemistry or pathology or microbiology or radiology. In fact, they are very, very important people for us to come to a reasonable diagnosis. So you should make very good friends with the biochemistry, pathology, microbiology, radiology. Okay. So the measuring the TSH level, thyroid hormone levels, T3 and the T4, and antibodies. So lab means not only the TSH, of course TH is the most important, but as initial investigation of the choice. So definitely don't diagnose the thyroid disorders on TSH alone. So first you get the TSH and also the free T4 or the total T4, free T3 or the total T4, T3, and also antibodies in some cases. So because antibodies also plays a major role in some cases where you have to initiate the levothyroxine therapy or not. For example, so subclinical hypothyroidism. Not all subclinical hypothyroidism we treat. We treat the overt hypothyroidism. But subclinical hypothyroidism also we treat provided the person is having autoantibodies, thyroid antibodies. So presence of the thyroid antibodies is an indication to start medication in the subclinical hypothyroidism. What are the other indications to start therapy in subclinical hypothyroidism? Good. Symptomatic. Okay. In all the symptomatic hypothyroidism, even though the TSH is between 5 and 10, you start. One is the antibodies positivity. Okay, fine. What is the third indication? Pregnancy. Excellent. Pregnancy. We should treat even at 4, even at the 3. Provided in the first trimester, our goal is 2.5. In the second trimester, our goal is 3. In the third trimester, our goal is 3. So when the 3 TSH in the first trimester, you start therapy. Very good. So presence of the autoantibodies, symptomatic, pregnancy, anything else? Presence of the goiter. So presence of the goiter you should treat. All the goiters you should be treated. Okay. So hypothyroidism and goiter you should treat. You should treat. So the TSH is the most sensitive indicator of the thyroid function. So TSH is the most sensitive indicator of the thyroid function. So why? See here. I told you very clearly that. See in the blue one, that is the TSH, and the red one, that is your T4. See the lot of the changes when the TSH will be there, but in the T4, very little changes. Very little changes. So that is the beauty of this slide. This slide clearly shows that a 2-fold change in the free T4 can correlate with a 100-fold change in the TSH. What is the normal T4, free T4? 0.02. 2-fold means 0.02 to 0.04. But TSH, 100-fold differences. From 5, it may be 500 also. So don't think that 0.03 T4, free T4 is normal. No, you should think that when the free T4 is just elevated by the twofold, there will be 100-fold rise in the TSH levels. So TSH is inversely proportional to the thyroid hormone levels. Hypothyroidism, high TSH, either low or the normal T4 and the T3. So hypothyroidism is divided into subclinical and clinical. What is subclinical? High TSH with normal T4 and T3 is the subclinical. What is overt hypothyroidism? High TSH with low T3 and the T4. In the same way, thyrotoxicosis is two types, subclinical and overt. Overt hypothyroidism or thyrotoxicosis means low TSH and high T3 and the T4 levels. Low TSH but normal T3 and the T4 levels. That is subclinical thyrotoxicosis, subclinical hyperthyroidism. So in all the subclinical, either the hypo or hyper, the difference is only the TSH. The T3 and T4 will be the normal in subclinical. So in hypo, you will have high TSH. In hyperthyroidism, you will have the low TSH. Whereas the overt, either hypo or the hyperthyroidism, you will have the changes in the T3 and T4 levels also. This is very, very important. So don't diagnose the cases with only TSH alone. Measuring the TSH in the clinical practice. So the third generation assays. These assays can pick up a TS change of 0.01 to 0.04 micro international units per ml. So this is the very important. You should remember what is the values, TSH values, micro international units per ml. So 5 or 10 or 80 or 50 of the TSH. So as a consultant you say TSH is 50 or 10 or 100. But you should say 50 micro international units per ml. So consideration the TSH testing, when to be done. So all these years we thought that TSH should be done on the fasting only. Okay. So that is our general public concept. So thyroid test should be done on the empty stomach, like your fasting blood sugar. Is it true? So fasting is not needed. Morning before 10 a.m. best time to the test. So timing is not critical for the TSH measurement. Okay. In the same way, your lipid profiles. Usually they give fasting. So timing is not critical for your lipid profiles also. So the only change with the lipid profile with the food is triglyceride levels. Triglyceride levels. Your LDH will be the normal, where the fasting or the postprandial. Your HDL will be normal. Your total cholesterol will be normal. But the only change is triglyceride levels. This is the upper limit of the TSH, variation with the years. So at birth, suppose the TSH is 6. 30 minutes after birth, it rises to 60. 60. So second day, 20. And slowly in the adulthood, it will come down to 4.2. 4.2. So this is the pregnancy ranges. So normally 0.5 to, we remember as 0.5 to 5 or 0.5 to 4.5. But actually it's 0.4 to 5.2. In pregnancy, first trimester, 0.1 to 2.5. Second trimester, 0.2 to 3. Third trimester, 0.3 to 3. Here later they have given. So the normal ranges are SS specific and may change as per the laboratory. So this is very important as a physician point of view. Fallacies in the TSH interpretation. See, these values may be suppressed due to severe illness as well as the drugs. So that is the reason we have to see the thyroid profiles when the fellow is in the ICUs. If you get the thyroid profiles in the ICUs, they are totally different when the fellow is normal. Because in the ICUs, in the critical illnesses, so the FSH values may be suppressed. TSH levels may be suppressed, and don't think that it is because of the hypothyroidism and start giving a neomercazole, etc. etc. TSH do not differentiate between the bioactive TSH and inactive TSH isoforms. TSH levels alone may miss pituitary disorders associated with the thyroid function. as TSH may be inappropriately normal there. If pituitary disease is suspected, measure the both TSH and the free T4. Certain antibodies can interfere with the test by spuriously raising the TSH. So what I mean to say, in the critical illness people, so don't TSH levels or the T4 levels and then diagnose as a non-critical illness fellow. So the normal fellow is totally different from the illness, critical illness, as far as your TSH and the T4 levels are concerned. So they may be suppressed or they may be elevated. So common drugs that affect the TSH measurement. Steroids. We often use the steroids in the ICUs. Dopamine, yes. Somatostatin analogs, vitamin A derived drugs are retinols, carbamazepine, valproic acid, metformin. So these drugs will alter the TSH levels. Especially the metformin is very commonly used drug, and the dopamine in the ICUs and the steroids. So this is the very important conditions where the TSH estimation alone may be misleading. Suppose when the TSH levels are very high, so what you thought? TSH levels are very high, hypothyroidism, but poor compliance. The patient is not taking the drugs. So each bottle is containing about 100 tablets. The patient review after the 3 months to you, but you check the tablets, there are already 50 tablets are there in the bottle. So that means he has taken only 50 tablets. The poor compliance. So the poor compliance, what will happen to your TSH levels in hypothyroidism? Obviously, they elevate. So this is very important. Unnecessary dose increase. Otherwise, what you do when the fellow is getting the 50 mcg of your thyroxine, in the review visit, the TSH is elevated, say 20 or 25. So what you do? You have to increase or decrease? You have to increase it, provided the compliance is the good. So if the patient is the poor compliance, so definitely you have to tell them that this is a lifelong disease. You have to take the every tablet morning early hours. So take it regularly and review after 3 months with again TSH levels. So without the poor compliance, what will happen to your TSH levels will increase. So when the fellow is having the good compliance and the TSH levels are high, so what to do? Increase the dose. In central hypothyroidism, the TSH will be the normal. So they're missing the hypothyroidism. Okay, you thought that? Normal. TSH is the normal. But if you check the T3 and the T4 levels, they will be very much reduced. So that indicates that it is a central hypothyroidism. TSH producing the tumor. So the TSH could be normal or the high. So it misses the hyperthyroidism. TSH recovery after the toxicosis. They may be normal or the low, missing the impeding the hypothyroidism. Thyroid hormone resistance. So the whatever amount of the thyroid you give it, because of the resistance, the TSH will be very high or sometimes the normal. So the failure to diagnose the illness. Drugs like steroids, they cause the TSH low levels. So unnecessary evaluation when the fellow is on the steroid therapy. So it is important to measure thyroid hormone levels too in these cases. So don't think of TSH alone. So when you are dealing with the thyroid disorders, so not only the TSH, T3 and T4 levels are also very important. Otherwise, if you think the TSH is the only value, so these all the possibilities will be there. So misinterpretation will be there. So sometimes it may be high, sometimes it may be normal, sometimes it may be the low. So in spite of the either hypo or hyper, some other disease also you should diagnose, the central diagnosis. So free thyroid hormone assays, these tests measures the thyroid hormones that are not bound to the binding proteins. So 99.98% it is bound to the proteins in the T4 levels. In certain conditions where the binding proteins can change in the quality or the quantity, the free T4 is a better test of free or unbound or therefore active thyroid hormone. Not recommended in the routine practice. Some conditions associated with the altered binding of the thyroid binding globulin and the free thyroid hormone assays may be useful. So there is the increased binding and the decreased binding. This is concerning with your thyroid binding proteins. Serum thyroglobulin, clinical relevance. It is released in the blood by the thyroid gland. You know that from the colloid, you will have the thyroglobulin. So it stimulates the thyroid globulin production. TSH stimulates. After the total thyroidectomy, as in the thyroid cancer, as there is a little thyroid tissue, the serum thyroglobulin levels become low or undetectable because there is no thyroid tissue after your thyroidectomy. So no thyroid tissue means no thyroglobulin there to release more and more thyroid hormones. So high TG levels are used to detect the thyroid carcinoma recurrence after the surgery or the radioiodine treatment. In all the surgeries, they keep some remnant of the thyroid tissue. Some amount of the thyroid tissue will be left after the thyroidectomy people. So after thyroidectomy, what do you expect thyroglobulin levels? They are the high levels or the low levels? Low levels only because there is no thyroid tissue. But after thyroid surgery, after 2 years or 3 years, now you have the high levels of the thyroglobulin. So that means recurrence of the malignancy. So what are the remnant tissue is there that is producing more and more thyroglobulin? That means recurrence of the surgery. So recurrence of the cancer. So this is a very, very common point. So serum thyroglobulin usually to detect the post-thyroidectomy cancer recurrence. Stimulated thyroglobulin values are used. The TSH is raised either by stopping the levothyroxine or by injecting the recombinant TSH. As antibodies can alter or interfere with the TG estimation, serum thyroglobulin test should be done in such cases with a simultaneous anti-thyroglobulin antibody measurement. Other indications, thyroid agenesis or thyrotoxicosis factitia. So this is a good slide, shows you, see the blood vessel on the top and you have the necklace of the follicular cells and inside you will have the colloid and thyroglobulin. So the antibodies to the thyroglobulin there. And then the antibodies to the thyroid peroxidase, TPO antibodies. They are very commonly, we check TPO antibodies in these population. So there, that is iodine, trapping, and diiodothyrosin, monoiodothyrosin. There, your thyroid peroxidase will help there. So antibodies to thyroid peroxidase. So also will be possible to detect it. And then the antibodies to the TSH receptor. Okay. So TSH is the most important hormone to stimulate your thyroid to release more and more T3 and the T4. So these three antibodies are available in the market. And mostly we'll get it TPO antibodies, the thyroid peroxidase antibodies. So other two antibodies are thyroglobulin antibodies and TSH receptor antibodies. So the TPO, thyroid peroxidase, an enzyme is important for thyroid hormone biosynthesis. Antibodies to TPO are positive in autoimmune hypothyroidism, 100% autoimmune thyroiditis. 80% is the Graves' disease. And 10% of the normal subjects, they are at higher risk of hypothyroidism in the future. So this is the important take-home point. So sometimes, Hashimoto's thyroiditis runs in the families. So the one fellow is Hashimoto's thyroiditis, already hypothyroidism. We have started on the hypothyroidism, levothyroxine replacement therapy. So to check whether the autoimmune thyroiditis is in the family members are there, you check the TPO antibodies. TSH normal. Get the TPO antibodies. So when they are positive, so even in the 10% of the population, so these population are at high risk of getting the hypothyroidism in the near future. So this is very important for TPO antibodies. Anti-TPO antibodies indications for the measurement used to detect the thyroid autoimmunity in the diagnosis of autoimmune thyroid disorders, whether it is Hashimoto's thyroiditis or the Graves' disease, both are autoimmune, especially the subclinical hypothyroidism with the TSH less than the 10. So that's what I told you. When the subclinical hypothyroidism means TSH between 5 and 10 micro international units per ml. So in such situations, when it is between 5 and the 10, when the TPO antibodies are the positive, that means high chances of converting to the hypothyroidism. So you have to treat it with thyroxine replacements. Pregnancy and the postpartum thyroiditis. As a risk factor for hypothyroidism during the treatment with the lithium or amiodarone therapy. It's a one-time test with no utility in the repeat testing. So just like your GAD65 antibodies. So when you are in a doubt whether the patient is a type 1 diabetes or type 2 diabetes, we get the GAD65 antibodies and C-peptide levels. So C-peptide levels will be very low that is type 1 diabetes. GAD65 antibodies positive, that means autoimmune destruction of the pancreas. So only once in the lifetime. So you need not repeat the C peptides and GAD65 antibodies always and always. In the initial days, when you are in a doubt with the type 1 and the type 2, you get the test done. The same way here. So it is not the test to repeat again and again. Anti-thyroglobulin antibodies, limited use. They do not predict the hypothyroidism accurately. So anti-TPO is the better test. The main clinical use of anti-TZ antibodies is differentiated thyroid cancer as an adjuvant to the thyroglobulin test. Again, the TSH receptor antibodies, very rarely we do it. This is the very important interpretation of the thyroid function test. So as a physicians, you should know how to interpret all these things. For example, serum TSH is the normal, T4 is the normal, free T3 is the normal. So what is our inference? When the TSH is high, free T4 is low, T3 is low. So what is our diagnosis? TSH high undi, T3 and T4 normal ga unte, that is subclinical hypothyroidism. And after the TSH, we give a lot of respect to the which hormone? T4 or T3? T4. So this is the very important. After TSH, we give a lot of respect to the T4. So when the T4 here, it is low. So that means thyroid hormone production is reduced and the TSH production is high. So that this means the defect is in the thyroid gland. So that is the overt hypothyroidism. Overt hypothyroidism. In the second way, see the TSH is high, T4 is normal. So what is the diagnosis? Subclinical hypothyroidism. Subclinical hypothyroidism. Okay. So when the TSH is low, T4 is high, T3 is also high. So that means it is hyperthyroidism. Hyperthyroidism. So the T4 is low, T4 is normal, and T3 is the normal. That is subclinical hypothyroidism. So don't confuse. We are very clear, very clear on the. So central thyroid dysfunction. This is very important. Sometimes you see such cases of central thyroid dysfunctions. See the normal or the high, TSH. See normal or high. If you check the TSH alone, it could be normal only. But what is the T4 and the T3? They are the very, very high. So that is the diagnosis. TSH mediated hyperthyroidism. So central defect. So you have to get the MRI of your thyroid gland, pituitary gland, hypothalamus, etc. And sometimes you may subject for the surgery also. See the TSH normal or low, but the T4 and the T3 low or low normal, that is hypothyroidism. So in central hypothyroidism, the TSH may be the normal or low, where your T4 and the T3 also reduced. All the three are the reduced. Low. That is central hypothyroidism. So central hypothyroidism, serum TSH may be low, normal or slightly high also sometimes. So moving to the common imaging modalities of the thyroid gland. So here we have to respect the radiology people. Thyroid ultrasound. High resolution ultrasound is the most cost-effective imaging of the thyroid. It can define the thyroid structure and detect the surrounding lymphadenopathies. It can characterize the thyroid nodules and is an adjuvant in the diagnosing the thyroiditis. So while seeing the ultrasound thyroid gland, you can know the size of the thyroid gland, any enlargement of the right lobe or the left lobe, or any masses is there, or nodules are there, and then what of the vascularity? Is it highly vascular or it's normal vascularity, or whether it is any malignance or the hot nodule or the cold nodule, and also surrounding lymph nodes. So when the surrounding lymph nodes are there, when it is a very big nodule is there, so most probably it is of malignancy. So the thyroid ultrasound will help us a lot in diagnosing the thyroid simple nodule, maybe the toxic nodule, maybe the multinodular, maybe the thyroid malignancies, or a simple enlargement of the thyroid that can be seen with your autoimmune thyroiditis like Hashimoto's thyroiditis. So the ultrasound thyroid is also very, very important investigation to be done in some of the cases when you are feel goiter. See here the thyroid. Ultrasound examination of the neck in the transverse plane showing the normal right thyroid and the isthmus. Left lobe of the thyroid gland in the transverse plane showing a rounded lobe of the goiter. See the right picture and the left picture, left and the right. In the right you can find a lot of the nodule is there. That L1 is a big nodule, enlarged lobe. 34-year-old lady notices a round swelling on the right side of the neck that moves with the deglutition. This is a very important investigation, clinical examination. So any mass, you ask the fellow to deglutate. So it moves with the deglutition. So definitely it attaches to your thyroid gland. She is otherwise asymptomatic. So in other words, she is having a thyroid mass, thyroid swelling, asymptomatic, no lymph node. The thyroid functions are normal. So as goiter, asymptomatic, no lymph nodes, TSH or the T3 or the T4, they are the normal. So what to do? Would an ultrasound of the neck will help here? So this is the case. Yes. See the normal thyroid ultrasound. The center one is the isthmus, the left lobe and the right lobe. See the adenoma here. Okay, large, well circumscribed, oval shaped adenoma. Hyperechoic nodule in the thyroid lobe. Slight heterogeneous appearance due to the presence of a few tiny cystic spaces and the clefts. Thin hypoechoic capsule is noted peripherally. Okay. See the difference here. See the change here. Adenomas. Circumscribed. Totally demarcation is there with the normal tissue on this adenoma. Okay. See the malignancy here. So the vascularity is there or the not. So right lobe of the thyroid shows a solid cystic tumor, solid internal nodule and thick walls, irregular shape and border, taller than the wide space. Color Doppler, increased vascularity in the solid parts of the tumor. Indications for your ultrasound. Confirm the thyroid nodule when the physical examination is equivocal. When you are in a doubt, so get the thyroid ultrasound. So that gives you a beautiful pictures. To measure the nodule dimensions, structure and the vasculature. As an adjuvant for the differentiate between the benign and the malignant masses. Malignant masses more vascular, benign, non-vascular. Distinguish the thyroid nodules from the other cervical masses like the lymph nodes. Adjuvant to the diagnosing the thyroiditis, the diffuse coarse ecotexture. Detect the postoperative thyroid tumor recurrence or the lymph node metastasis. Screen high-risk patients for thyroid malignancy like patients with irradiated neck to guide the diagnostic FNAC. So these are all the beautiful indications for your thyroid ultrasound. X-ray deck, useful to detect the tracheal compression, so especially in the malignancy population. In very selected cases, this is a useful pre-surgical assessment tool. Anesthesia and intubation problems can be identified before the surgery. A 44-year-old lady presents with a diffuse goiter. See the goiter, very big in size, mostly on the left side. For 10 years, she has dyspnea on lying down and is also an asthmatic. So would an X-ray of the neck help in this assessment of this case? So let us have an X-ray. See the tracheal shift to the right. Okay. So the mass is on the left side. Trachea shifted to the right side. See the amount of the mass there. Very big thyroid enlargement. See the large goiter compressing the trachea. Additional imaging CT neck. Not usually required, maybe an optional preoperative imaging. Thyroid scintigraphy is a procedure producing one or more planar images of thyroid using a radio labeled isotope. Okay, radioisotope scan. So thyroid scan, isotope scan. The uptake or lack of it by the thyroid is defined and imaged for evaluating thyroid function status. So there are the advantages and the disadvantages. Less expensive, more readily available, more rapid examination. Nuclear scintigraphy, thyroid, some causes. A 55-year-old lady comes with a thyrotoxicosis. T4 is 19 micrograms per deciliter. What is the normal T4? Normal T4. Here the TSH is 0.0001. See how much reduced TSH. Normal is 1.5 to 5. Okay, but here it is 0.001. See the nuclear scan. Nuclear scan, diffuse uptake. This suggests the Graves' disease, a common cause of thyrotoxicosis. Both the lobes, the entry of the material is there in both the lobes. So it's a diffuse and enlargement. So most in favor of thyrotoxicosis, the Graves' disease. A 47-year-old male presents with history of right-sided neck nodule. A right-sided thyroid nodule, 4 into 2. A male fellow, thyroid nodule, 4 into 2 centimeters. Thyroid function tests are the normal. Ultrasound shows intermediate risk. Patient refuses to do an FNAC, but requests additional imaging instead. So is afraid of the FNAC. So any other tests? So would a nuclear scan help here? So definitely. See the uptake. Which one is higher? Which side is lower? Uptake. Which lobe? The defect is here is in the right lobe. Less isotope uptake, cold nodules has a higher chance of malignancy compared to a hot nodule. Left lobe is here normal, but the right lobe, the molecule take up is very low. So that called cold nodule. So the cold nodule is more dangerous, more of malignancy nodule here. So nuclear scans of the cold nodules are neither specific nor sensitive and are not recommended routinely. See the uniformly reduced uptake of the thyroid. No thyroid gland on the left side. Only right lobe is there. Left lobe is not there. So introduction to the common thyroid disorder. So before that, so what are all some points of the thyroid you know of? Investigations wise. So respect the lab. T3, T4, TSH, etc. And then the ultrasound thyroid is very important. So radiology population. Then the FNAC in some cases to identify the early malignancies. Okay. And sometimes some people may require isotope scans. So iodine deficiency and the cretinism is a very common. Hypo and thyroid nodules and thyroid cancers. So this is the iodine, a vital element in all the thyroid hormones. Plasma iodine, thyroid iodine, deiodination, oxidized iodine, tyrosine, triiodotyrosine and thyroxine. Iodine biochemical, photochemistry. See the coastal emissions, sea, air, gas transfer, organoiodinates and iodines. So iodine is very commonly seen in seawater. In India, deficiency in India. In India, the entire population is prone to IDD. That means iodine deficiency disorders due to the deficiency of iodine in the soil of the subcontinent. In Delhi, the median urinary iodine levels were 35 mcg, suggesting the deficiency. More than 100 mcg is considered adequate. Adequate is more than 100 urinary iodine levels. But in Delhi, it is only 35. So in the North India, very, very low levels of the iodine. So more and more chances of getting thyroid disorders. In Kerala, the median is 162 in 2 studies indicating the adequacy. So South India, good. Whereas in North India, very poor. The spectrum of the iodine deficiency disorders across the lifespan. In pregnant women, fetuses and the newborn. So what is the TSH levels in the first trimester? 0.1 to 2, 2.5. Okay. Second trimester? 0.2 to 3. Third trimester? 0.3 to 3. So 3 is common, second trimester and third, upper levels. But lower level, 0.2 in the second trimester, 0.3 in the second trimester, third trimester. So in pregnant women, fetuses and newborn, if you neglect at that stage, so there will be the decreased fertility, spontaneous abortions, stillbirths, congenital abnormalities, neonatal mortality, cretinism, and psychomotor defects. Very simple test, but often most of the people, they don't do it, especially in the rural India. So it's very, very common. So in pregnant women, fetuses and the newborns, especially we are concerned with the pregnant women. Okay, so we get some referrals from the department. So what to do? So these are, if you neglect the hypothyroidism or thyroid test there, so you will have all these infections. In infant children and adolescents, there will be the hypothyroidism with iodine deficiency, impaired coordination, impaired mental function, IQ lower, retarded mental and the physical development, a diminished school performance. In adults, goiter and its complications, hypo, impaired mental function, lower energy and the productivity. So these are in adults. These are all the, see the importance of the iodine. Iodine deficiency will cause all these things. Hypothyroidism, deficiency of the thyroid hormones, 2 types, primary and secondary. So the types of the hypothyroidism here. So the pituitary normal, so secretes the TSH. Thyroid gland is also normal, secretes the T3 and T4 normally. So you are dealing a normal patient. Thyroprivic, that means high TSH. So the thyroid failure, low T3 and low T4. So the primary hypothyroidism. Low TSH, thyroid is suppressed. So there will be the low T3 and low T4. So this is the central hypothyroidism. So primary hypothyroidism, secondary hypothyroidism, you please concentrate here. In the primary hypothyroidism, defect is in the thyroid gland. In the secondary hypothyroidism, it is the defect is in the either in the hypothalamus or in the pituitary. Because it is not getting the TSH to reduce more and more TSH. Hypothyroidism in India, increasing over the decade. That is the most important thing. So we are seeing more and more cases of the thyroid because of the increased incidence. See the overt hypothyroidism, subclinical hypothyroidism. In the year 2000 and the year 2010, you see goiters 0.89, 1.2. Subclinical hypothyroidism in the year 2000, 4.3%. Now 10.3%. Girls, boys, non-goiters, etc. So that all the people, we are seeing more and more cases of the thyroid in spite of the iodized salt. In spite of the iodized salt. So undetected hypothyroidism in Indian adults, 8 cities, they did a study. So overt hypothyroidism is about 3.5% and subclinical hypothyroidism is 8%. Is it common or uncommon? Very common disorder. Very common disorder. So as a physicians, so hypothyroidism we should not miss it. Either hyper or hyper. So thyroid. Prevalence of the hypothyroidism from the South India. South India. So prevalence of hypothyroidism was 3.9%, nearly 4%. So in a country like India with 140, 150 crores of the population, even 1% is also very high in numbers, very high in numbers. Prevalence of the subclinical hypothyroidism was also high, nearly 10%. In South India, we're having more hypothyroidism here. 33-year-old lady, severe constipation, cold intolerance, menorrhagia. TSH 127, free T4 undetectable. So what is your diagnosis? Two types hypothyroidism. Good. So as the class is at the end, nearing the end, you should come to a very reasonable diagnosis. Good, hypothyroidism. Which hypothyroidism? See the T4, not detectable, very low. So that means overt hypothyroidism, clinical hypothyroidism, not subclinical hypothyroidism. So he also had complications, symptoms, severe constipation, cold intolerance, menorrhagia. Age 33 years. So what is the treatment? Oh, good, levothyroxine, very good. How much dose you give it? Good, 1.6 into kg body weight. 1.6. Some people give 1.7, but you remember 1.6. 1.6 into, see the weight of this patient is maybe 70 kgs. Cheppamma now, what is your dose? 70 kgs. What is your dose? 70 kgs. 70 into 1.6. 112 is also available. Or give it 100. 125 is also available. Not give 125. Okay. Exactly 112 is also available in the market. Give 112 or give 100 only. So that's how you have to calculate. Suppose the weight is 100 kgs. That is 3-year-old 100 kgs. How much you give? 160. Excellent. Give 150 is available. Give 150 once a day. Only once a day. Empty stomach. Okay. So that's how you have to treat it. So this is a very important hypothyroidism. Okay. 32-year-old lady married for 8 years. Comes with infertility. Infertility. Very, very common with thyroid disorders. Clinical examination is unremarkable. Free T4 is 1.2 micrograms per deciliter. Normal is 0.8 to 2. TSH is 6 micro international units per ml. So what is the case here? Is it hypothyroidism? Good, subclinical, because T4 is normal here. T4 is normal, but TSH is more than 5. So subclinical hypothyroidism. So common with infertility. So what is the diagnosis? Subclinical hypothyroidism. So how do you treat? What is indication to treat here? Subclinical indication to treat here is infertility. So infertility, pregnancy, symptomatic, goiter, TPO antibodies positivity, these are the indications to treat even though the patient is subclinical hypothyroidism. 5 or 6 indications ఉన్నాయి. ఒకటి presence of goiter, pregnancy, infertility, symptomatic, TPO antibodies positivity. Okay, so here one indication is infertility, subclinical hypothyroidism. You treat. Okay, so how do you treat? Treating with which drug? Levothyroxine. How much? So subclinically don't 1.6, maybe half of the dose we start it. Okay, so now start with maybe 50 or 65. So thyrotoxicosis, a condition where thyroid gland produces excess thyroid hormones. Thyrotoxicosis refers to the state of the excess effects of thyroid hormones in the blood. Not all cases of thyrotoxicosis are due to hyperthyroidism. This is the very important. Thyrotoxicosis is different from hyperthyroidism is different. Hyperthyroidism means the defect is in the thyroid gland only. Whereas thyrotoxicosis, the defect may not be from the thyroid gland. Am I clear? Thyrotoxicosis is different from hyperthyroidism. Hyperthyroidism means you are pinpointing the organ. Where is the defect in hyperthyroidism? Defect is in the thyroid gland itself. Whereas in thyrotoxicosis, anywhere. It could be thyroid gland, it could be ovary, or it could be something else also. So that is the difference between thyrotoxicosis and hyperthyroidism. When you are saying it is hyperthyroidism, so the defect is in the thyroid gland itself. So causes of thyrotoxicosis without hyperthyroidism. So the thyroid gland is a normal here, but hyperthyroidism or thyrotoxicosis is there. The excessive intake of levothyroxine tablets. So obviously the people who present with thyroid, excess thyroid symptoms. Thyroiditis, the damaged gland releases the hormones. Rare, ectopic thyroid hormone production. So our thyroidosis is hyperthyroidism. So how common is hyperthyroidism in India? Overt hypothyroidism, 0.72%. Subclinical hyperthyroidism, 1.2%. Combining, nearly 2%. Okay? So not very rare. 2% in Indian population. Again, very, very high. So both hypothyroidism and hyperthyroidism, as a physicians, you should know much about these things. So prevalence in South India, see 1 to 2% of the subjects. So prevalence of the thyroidosis was 2%. Prevalence of subclinical hypothyroidism was as high as, also high at 1%. Swellings, goiter, is the enlargement of the thyroid gland. Thyroid nodules, discrete lesions within the thyroid gland are also common. 9.6% of adults have a goiter. 5% of the adults have a nodule or the nodules. See the difference. Lot of the people, even though we have urban population, so we may not have the much goiters here. But the rural India, so they have a lot of the goiters and a lot of the nodules. So data shows that 4.6% of the men, 5.6% of the women have the discrete nodule or the nodules, multiple nodules. So nodules are common, but thyroid cancer is rare. 9 out of 100 have thyroid swelling of the nodule. 1 in 1000 may have the thyroid cancer among the nodules. So take home messages from the part 1 of our thyroid. Next week also we will continue the thyroid. Thyroid diseases are common or uncommon? Common. Commonly measured hormones are, reverse it, TSH and free T4. TSH is the best indicator of thyroid diseases. Thyroid antibodies, particularly TPO antibodies, signify the thyroid autoimmunity. Ultrasound is the best imaging of the thyroid nodule. Nuclear scanning is useful in selected cases, whether it is a hot nodule or the cold nodule, etc. Okay. So I stop here. Any doubts?